Good afternoon, and welcome to the Brain and Behavior Research Foundation's Meet the Scientist monthly webinar series. I'm Dr. Jeff Borenstein, President and CEO of the Foundation, and your host for today's webinar. Today, Dr. Lisa Pan will present Metabolomics and Psychiatric Disease, NextGen Frontiers in Pathophysiology and Treatment. The Brain and Behavior Research Foundation is committed to alleviating the suffering caused by mental illness by awarding grants that will lead to advances and breakthroughs in scientific research. The Foundation is the largest private funder of mental health research grants. Since 1987, the Foundation has awarded more than $360 million to fund more than 5,000 grants to more than 4,000 scientists around the world. 100% of all donor contributions for research are invested in our grants to scientists who are working to find breakthroughs in disorders such as ADHD, anxiety, autism, bipolar disorder, borderline personality disorder, depression, OCD, PTSD, addiction, and schizophrenia. I'm delighted to introduce Dr. Lisa Pan. Dr. Pan is Associate Professor of Psychiatry and Clinical Translational Science and Human Genetics at the University of Pittsburgh School of Medicine. Dr. Pan is also the recipient of a 2012 NARSAD Young Investigator Grant. Today's webinar will begin with Dr. Pan's presentation. This will be followed by a question and answer period. To submit your questions, please use the Questions tab on the control panel on your screen. Feel free to submit your questions throughout the presentation. Following the presentation, I will ask your questions to Dr. Pan and will address as many as possible in the time allotted. And now, I'm pleased to introduce Dr. Lisa Pan. Lisa, the floor is yours.
Thank you so much, Dr. Borenstein. I really appreciate this opportunity, and I really appreciate the funding from the Brain and Behavior Research Foundation that allowed the work to begin. Sorry. So first I'm going to have a discussion of treatment refractory depression. I'm going to discuss a case report and a case control study that we did looking at metabolomics in depression. I'm going to talk about new diagnostic and treatment approaches to treatment refractory depression, and then talk a little bit about future directions for our current work. So first, I wanted to talk a little bit about what we know about metabolic disorder and psychiatric disease. We know that inborn errors of metabolism have neuropsychiatric manifestations. So these are disorders that are associated with gene changes or changes in metabolism that can often present as emergencies or have chronic fluctuating symptoms, or can be associated with neurologic decline and mental retardation. Specifically, there are known psychiatric manifestations of intoxication syndromes where metabolic disease causes changes in the biochemistry of the body so that there's toxic effects, and also in storage disorders and disorders of energy metabolism and metal storage disorders. We hypothesized, however, that milder central nervous system disease had specific metabolic disorders that could present with later onset and isolated psychiatric symptoms, and these really hadn't been described previously. So I want to talk a little bit about how I came upon this hypothesis. I work in a clinic, which is a tertiary care center for suicide prevention and depression, and our patients are at the extreme end of depression severity, so often there is a history of suicidal behavior and depression that's not responded to multiple treatment trials. And the young man that brought me to this study has given permission for me to share his information. And his story and the treatment that he received is actually published as well. So he first presented with depression and self-injury at age 11. He had his first suicide attempt at age 14, and he came to me after a very serious suicide attempt at age 15. What had occurred is that he had pretended to go to school, come back home, and taken over 80 pills, including narcotics and antihypertensive medicines, blood pressure pills, and was unconscious. And he was discovered by chance because someone in his family had forgotten something at home. He needed emergency care and had an intensive care unit stay. So this was very close to an actual death by suicide because of the lethality. It's important to note that he, in the history of his treatment, had no response to available medications. We had tried experimental treatments and drugs from almost every class without a response. And at one point in the hospital, he was taking 17 different medications with neither a response nor side effects. At age 18, he had 32 ECT treatments, but only had about 6 days of improvement, and immediately became worse after that period passed. We readmitted him and tried ECT again. So ECT is electroconvulsive therapy or shock therapy. And with the second trial, he had no response and refused to continue with the treatment. He ended up having a very long hospital stay and had no response of his suicidal ideation despite aggressive treatments. And this, I show this slide primarily to show you that in the red circle up here at the top, you see that at one point he's on every class of medications before we discovered the cause of his illness. So we had exhausted all the available therapies and medication classes, and in light of his severe depression and suicidal behavior, we talked with both genetics and a cardiologist. There were a couple things that made us do this. One was that he had a very mild aortic dilatation, so his aorta was a bit loose. And we were concerned about the possibility that this was part of a genetic syndrome that was causing the depression and this vascular change. In addition, there had been a study in the 1980s at National Institutes of Health showing that patients like him with severe near-lethal suicide attempts had low metabolites of serotonin in their central nervous system. So this was done with cerebrospinal fluid testing, and what it showed is low levels of a metabolite called 5-hydroxyindolacetic acid, which is a breakdown product of serotonin. And so I went to Dr. David Feingold in our Department of Genetics and asked if there was any way we could do cerebrospinal fluid testing to give me some hint about his neurotransmitter status so that I might have a new way to treat him. And so this is what led to the testing. We ended up doing an evaluation of his blood, urine, and cerebrospinal fluid, and his cerebrospinal fluid neurotransmitter analysis showed a very severe depletion of all the intermediates of a small molecule called tetrahydrobiopterin or biopterin. So the reason biopterin is so important is that it can lead to no production of serotonin. It's also important for dopamine metabolism, for pain modulators, for melatonin, which helps regulate sleep, for norepinephrine, and so it affects all of the neurotransmitter metabolism and can lead to psychiatric symptoms. Here is the pathway for serotonin development that it affects, but it has really broad-reaching effects when it's absent. And so this is just a very simplified pathway showing what I just talked about. This is the generation of both serotonin and dopamine from tetrahydrobiopterin. And on the right, you can see his cerebrospinal fluid studies. So 5-hydroxyindolacetic acid was low. This is the metabolite of serotonin I just talked about. Homovinilic acid, which is a breakdown product of dopamine, was low. BH4 was low, and this looks like a mild issue because it's close to the range, but just a little bit below. But it really does have devastating effects. A healthy person his age should be in the high normal range. And neopterin is a breakdown product of tetrahydrobiopterin, and we saw that was lacking also. And so this was an indicator that this pathway was really affected. So what was wonderful about this discovery is that this chemical this small molecule tetrahydrobiopterin is made as a medication called sapropterin. Sapropterin is used to help break down phenylalanine for phenylketonuria, but we were able to repurpose this as a replacement therapy, and so we actually gave him the small molecule he was missing. In the first 4 weeks of treatment, he reported feeling like he could make decisions better and not seeing suicide as an option, even though he felt very depressed. In the weeks that followed, he also reported some odd emotionality, including crying about small things, things like that he would see on the television, and even inappropriate feelings of love towards people that he shouldn't have those feelings towards, and some mild hypomania. At one point, his mother told me that he landscaped the yard during this period of time. His suicidality had resolved, but he still had low mood. And so we gave him the precursor of serotonin because we knew it was low in the central nervous system. And I feel like this is really important to say. You would not want to give serotonin, even though it's available over the counter, to someone if you didn't know if their serotonin levels were low, because you could cause a life-threatening reaction called hyperserotonemia. In addition, with the serotonin precursor, we had to give carbidopa, which protects the blood and the peripheral part of the body from the effects of serotonin and allows it to move into the central nervous system. So again, this should really be done only with prescription carbidopa and physician supervision. It's important that to say that the patient remains stable 5 years later. He continues to function very well. He was able to go to college and graduate and have employment and high functioning and meaningful interpersonal relationships. He still reports appropriate periods of low mood around stress, but nothing like the depression that he initially presented with. And we've also had 3 other patients with a similar discovery who are starting to respond to the subpropterin replacement. So when this happened, we were really, even though it was in one individual, very impressed by it and wondered who else we should test. Again, we have a clinic with patients who have not responded to available treatments. And so we began looking to see if anyone else might have a disorder like this. The next 3 patients we tested actually were found to have a metabolic disorder as well. Their metabolic disorder is called cerebral folate deficiency. And I'm going to talk a little bit about that with the first patient we tested after him. She was a young woman with significant major depressive disorder and very sudden onset of mood fluctuations. So she would be at really high risk because she'd have very rapid onset of suicidal ideation. She had a history of non-suicidal self-injury and multiple suicide attempts. And her symptoms would partially remit with high-dose serotonin reuptake inhibitor and cognitive behavioral therapy, but she would still have these sudden valleys that would be life-threatening. And so in addition to that, we would see a recurrence of non-suicidal self-injury that we were not able to control. And so when we tested her central nervous system, by testing her cerebrospinal fluid, we found that there were low levels of a breakdown product of folate called 5-methyltetrahydrofolate, which you see at the end of this folate metabolism diagram here. The reason this was relevant is that folate in her blood would look completely normal, but without testing her cerebrospinal fluid, we wouldn't realize the brain didn't have access to the folate it needed. Again, this is very important because folate's needed for neurotransmitter genesis, and it's important for neuronal health. So in the neurologic form of cerebral folate deficiency, we can actually see white matter changes on MRI that improve with treatment of the cerebral folate deficiency. And where we would give the replacement therapy is here where you see this yellow circle. What the treatment is for this is to give a form of folate that's already been broken down so the body doesn't need to act on it to allow it to cross over into the central nervous system. So her CSF testing revealed low 5-methyltetrahydrofolate with a level of 35, with the normal range being 40 to 120. Her neurotransmitter status was actually within normal limits, and that may have been related to medication dosing or the time of sampling, or it could have been related, her symptoms could have been related to the effects of folate on the structure of the neuron. It's hard to know. Plasma testing revealed normal hemoglobin, hematocrit, B12, and folate, so nothing would have indicated that there was a problem here from blood testing. In light of her low cerebrospinal fluid 5-methyltetrahydrofolate, we initiated treatment with folinic acid, which is a breakdown product of folate that I talked about, at 5 milligrams by mouth daily. The patient reported a reduction in mood fluctuation, resolution of suicidal ideation, and improvement in her mood in 8 weeks. She denied side effects. And I want to say that having gone forward and having found more individuals with cerebral folate deficiency, this is a rapid response. We've had some patients that have a rapid response, but in talking to physicians, Frederick Seidel in Paris, who takes care of this disorder in its neurologic form, it can take up to 3 years for the effects of folate replacement with folinic acid to have its full effect on neuronal structure. So it's important to know that this may not be a rapid response, though it was in this case. And I don't know, but my hypothesis is that there's an effect on neurotransmitter metabolism that's more rapid and an effect on brain health that takes longer. So folinic acid was increased to 10 milligrams by mouth daily at 8 weeks, and in the following months she continued to report improvement of her mood that was stable. And we now know that we should titrate to 1 milligram per kilogram, so that's the dose that we're using at this time, and she continued to have improvement as we increased the dose. So again, I just want to talk a little bit about what I said when I was discussing her case. Cerebral folate deficiency is believed to be caused by inefficient folate transport across the blood-brain barrier. It's a central nervous system specific syndrome with low 5-methotetrahydrofolate in the cerebrospinal fluid and normal folate in the plasma. And we think this is because folate has to be broken down to cross the blood-brain barrier. Therefore, the only way to diagnose this is at this time requires cerebrospinal fluid sampling by lumbar puncture. It's important to say too that low 5-methotetrahydrofolate can also contribute to the impaired tetrahydrobiopterin synthesis we talked about earlier because these two pathways interact. And so this is a complex biochemical pathway that can contribute to neurotransmitter metabolism deficiencies in a variety of ways. The reason we choose folinic acid or leucovorin and calcium for the treatment of cerebral folate deficiency is that it bypasses the deconjugation and reduction steps, so the breakdown steps for folate. And it allows the deconjugation to 5-methotetrahydrofolate without the action of this enzyme called dihydrofolate reductase in the body. It's then available for transport across the blood-brain barrier. Folinic acid is a vitamer of folate, so it has the same activity as the folate you would have in your multivitamin. And dosing can be titrated to 1 to 2 milligrams per kilogram or higher. There has been some questions that have come up as a result of the paper we published about the use of another form of folate. You can actually give 5-methotetrahydrofolate, which is the last step in the folate metabolism pathway. That is the appropriate supplementation if a person has a gene change in methotetrahydrofolate reductase, but that's a little bit further down the folate pathway, and that step has less effect on neurotransmitter metabolism, so that is why we went with folinic acid for treatment of this disorder. And we do the gene testing for MTHFR to clarify if we can figure out where in the folate pathway there's a problem. So I want to talk a little bit now about treatment-resistant depression and what that means. We know that 15% of depressed patients don't respond to available therapeutics. There's a high rate of disability and mortality due to suicide in this population, and historically, metabolomic approaches like I've been talking about have not been used to characterize treatment-resistant depression. So we began this investigative pathway after identifying our first patient and finding out that replacement therapy resulted in his recovery. We therefore conducted a case-controlled study supported by the Brain and Behavior Research Foundation to look at the prevalence of metabolomic abnormalities in patients with treatment-resistant depression. Our recruitment was from age 14 to 40 years. Patients had to have had at least 3 full-dose medication trials of 8 weeks that had not caused an improvement in their depression. The study required a testing of cerebrospinal fluid, blood, and urine samples. And I should say that the majority of patients have had far more than 3 full-dose trials. They've been very resistant, but we do have a few participants who have had 3 or 4 trials. We've collected 50 participants so far for whom we have all the results back and 18 controls. And I want to spend a little bit of time on this slide because these are our findings so far. So I think the important thing for me to point out is that of the 50 cases, 30 of these patients have had a metabolic disorder for which there's a different available treatment. And we had no idea we would be in the range of 60%. We thought maybe 10% would be a possibility. I also want to say that there are other findings that aren't reported in this table, including abnormalities on microarrays. So there are patients for whom we found some gene variants that we're trying to clarify the meaning. These are specifically disorders of metabolites that we have found abnormalities. Of the 15 cases, 19 of the cases have had cerebral folate deficiency, so that inability to break down folate and get it into the central nervous system that I talked about. We've had 4 patients with tetrahydrobiopterin deficiency, and just last week we found a 5th. We've had 7 patients who have an abnormal acylcarnitine profile, and I just want to talk about that for a few minutes. So an acylcarnitine profile lets you know that there's an abnormality of energy metabolism, but not necessarily the reason for that abnormality. This is a pathway that is affected by riboflavin, which acts as a cofactor. There are multiple transporters in this pathway, and in addition, disorders of mitochondrial function can cause an abnormality here. So what happens when we identify somebody with an abnormal acylcarnitine profile is that we refer to genetics for further evaluation to determine if we can understand what may have caused this change in energy metabolism. And in fact, all of these patients are referred for treatment. This study identifies the patients but doesn't provide treatment. So we refer to medical genetics for follow-up. One patient had Fabry disease, which is a disorder of cell membranes, and with infusion therapy to treat that disease, her depression improved. One patient has a disorder of creatine metabolism that we don't completely understand yet, and he moved out of state and is being evaluated at Duke University. And 20 of the patients had no identified metabolic disorder. Many of them had low 5-hydroxyindoleacetic acid, but there was not a cause identified, and so we continue to follow up on those patients now to try to understand. It's also important for me to say that none of the controls had any of these disorders. And so I think that's important in that we at least see an association with the treatment refractory depression status. So, so far, 60% of our affected participants have had an identified metabolomic abnormality. There's been new treatments available in the majority of the affected participants recruited so far. And again, we have not found these disorders in healthy controls. The clinical implications of this so far are kind of early, but treatment with folinic acid has resulted in sustained improvement of depressive symptoms in 9 of the 10 subjects for whom we've had adequate treatment time and follow-up. And we're very excited because in the coming months we're going to start bringing back the larger sample to see about their improvement, and so we hope to have more information about how many people are responding to intervention. The improvement's been evidenced by improved scores on the Beck Depression Inventory and the Suicidal Ideation Questionnaire, and new treatments are available based on the study findings for the majority of these participants. And I just, this is in our paper that was published in the American Journal of Psychiatry, but I just want to show you that there's a statistical change in improvement in the BDI with this follow-up period after intervention, and it seems that the longer the duration of the intervention, the more improvement we see. And then I want to talk a little bit about the next steps we've taken as a result of these findings. So right now, it's very exciting because basically what we're doing is looking at end metabolites in these biochemical pathways that we know are related to depression and neurotransmitter metabolism. But what we don't know is why the patients have these changes in their metabolism. So what we've done in concert with this metabolomics work is Dr. David Peters, who is my colleague in molecular genetics, has been doing whole exome sequencing for the participants in whom we find a disorder and their family members to see if we can find a gene variant that is related to the metabolite abnormality we're finding. So what whole exome sequencing does is it looks at about 100,000 data points of all the transcribed information from the genome. And then we have a wonderful postdoc named Laura McLean who's going through that huge set of data, looking at variants in areas we know are related to these biochemical pathways. And we're hoping that as we move forward, we're going to be finding variants and common pathways amongst these patients, even though we have a small sample. In one family with cerebral folate deficiency, we have already found and confirmed a variant in FOLR1, in which an intron 5 is retained. FOLR1 is important in that pathway because it encodes a receptor called folate receptor alpha, which actually binds folate and moves it across the blood-brain barrier into the brain. So in this one family, we've been able to identify a potential reason for the cerebral folate deficiency we found. And we're hoping that moving forward, we can continue to do that. And if we do find variants that are common to multiple patients, maybe we could even generate a test that wouldn't require cerebrospinal fluid. We are also working with Dr. Robert Navio at University of California, San Diego, to do another form of metabolomics called broad spectrum metabolomics. And I want to talk a little bit about that, and then I'll explain what you're seeing here. So the metabolomics work we've been doing is based on clinically available tests that have been established for neurologic and genetic disease. So it's the same thing if I would want to find out if you were anemic and I draw your blood and we compare it to a range of healthy people's blood volume and see if you're below the range. The testing I've talked about so far is like that. They're clinically available tests. I send them to a clinically certified lab and they're compared against ranges for normal people that have been established. Broad spectrum metabolomics is a little bit different in that, in this case, we're taking nearly 800 different metabolites and asking, are these 800 different metabolites different between patients with treatment refractory depression and healthy controls? And what we're finding out in very, very preliminary data is that the control group is completely separating from the depressed group. So right now, when Dr. Navio takes a set of metabolites, there you can tell which group the patient is falling into. And as we progress with more patients and we start identifying these metabolites and their relevance to these pathways, again, I'm hoping, because this is done in plasma, that we'll be able to have a blood test for some disorders, hopefully in my lifetime. Not immediately, but hopefully in my lifetime. And so I do think this is exciting, though, because we're seeing clear differences. So in conclusion, 60% of our treatment-resistant depressed patients have had metabolomic abnormalities. I think this is important in that for a patient in whom other treatments are not working, there's a possibility that we're missing a contributor to their depressive symptoms. The most common disorder we have characterized is cerebral folate deficiency, which is characterized by low cerebrospinal fluid folate and normal serum folate. The majority of the patients we've tested have shown symptomatic improvement with replacement therapies. So for the cerebral folate deficiency, replacement with folinic acid or 5-methyl-tetrahydrofolate. For the patients with energy and metabolism disorders, we're giving the cofactor while we're trying to determine the cause to help improve that pathway, and the cofactor is riboflavin. And then for the patients with tetrahydrobiopterin deficiency, like the first young man I talked about, we're giving cyproterone replacement. Metabolic abnormalities may be more common in treatment-resistant depressed patients than we previously thought, and may suggest novel, effective therapeutic approaches for patients who've been ill for a decade. For future directions, we're going to continue analyzing affected adolescents, evaluating blood, urine, and cerebrospinal fluid for evidence of metabolic disorders. We're also continuing our analyses of CSF and plasma with broad spectrum metabolomics. We're going to continue exome sequencing and functional studies to determine if the genes that we're identifying are in fact being transcribed and affecting these metabolic pathways. And we're also beginning metabolomics, where we're looking at markers of cell type damage in the cerebrospinal fluid to determine if these disorders are having an effect on the integrity of the brain structure. And just recently, not on this slide, we're also going to begin looking at diffusion tensor imaging using MRI, which will tell us about the white matter structure in patients with these metabolic disorders. I have a lot of people to thank who are involved with this study. It really involves multiple hospitals in our system, particularly David Brent, who has taught me how to manage suicidal behavior, Jerry Vockley, who developed the protocol we're using, Dave Peters, who is doing our gene testing, and David Feingold, who helps with our biochemical evaluation, and Dr. David Lewis, who supported this work since its infancy. And I really want to thank the Brain and Behavior Research Foundation for being the first funding agency to think this was relevant and important. And I also appreciate the opportunity to talk today. I did want to leave a significant period of time for questions because I'd received a lot of them by email already. And so if there are any questions, I'd be happy to take them now.
We do have a number of questions, as you mentioned, Lisa. First of all, thank you for your presentation and for your work. And I just want to say, this is an example of how we, the collective we, should never give up on anybody. And you treat people who have very severe depression, and your unwillingness to give up, to try to not to leave a stone unturned, helped that particular person, and also now is helping other people and the potential to help many other people in the here and now. So I want to thank you for that, and I know so many of the people who are affected by these conditions also thank you. So great work, and thank you. One of the questions that a couple of people ask in a few different ways has to do with, does this apply to conditions other than depression? For instance, does it apply to bipolar disorder, etc.? And I'd like you to speak a little bit about that.
Sure. So, and I think it's really important for me to start off by saying, this is very preliminary, and it's only in depression. And so I want to say that before we emphasize how important this is, I do want to say it needs to be replicated. It's a small group of people, but it is exciting, I think. And so we have only tested in treatment refractory depression, although we have allowed comorbidities. But what I can say is we know, for example, in the neurologic form of tetrahydrobiopterin deficiency, which is called Sagawa syndrome, and it's a BH4 deficiency like what I found in this patient, but it's associated with a severe neurologic decline. And we know that those patients will develop obsessive-compulsive symptoms, depression, really intense anxieties. And my guess is that depending on the effects of these metabolic changes on the brain, we could see a large range of symptoms. Furthermore, we know from previous studies in alcohol dependence that alcohol-dependent patients have low 5-hydroxyandilacetic acid. What we don't know is if that's something that is pre-morbid of the alcohol use or if it's affected by the alcohol use. But I'm hoping moving forward we will branch out and look at some other disorders and try to determine if there's a relationship between these metabolic changes and those disorders. Other observations we've made, again on a very small group of people, are that the patients we've identified with tetrahydrobiopterin deficiency have also had a history of eating disorder symptoms, but they have been wrapped in a very severe depression, so it's hard to know if those are separate. But there are these little hints that there may be other disorders that are affected by these metabolic changes, and so I think moving forward it's going to be really important to study that.
You presented the information about the patients you studied, including the control group. Those controls were people who didn't have depression at all.
Right.
Do you have any information on people who have depression but respond to treatment and whether or not they may have any component of this as well?
So yeah, the healthy controls that we collected were very, very healthy. So they had no history of any mental health problem, no history of substance dependence, no history of suicidal ideation, and no primary relative with any of those things. So they and their primary relatives were completely healthy from a mental health standpoint. We are really interested to study responsive depression to try to understand if these disorders are contributing to depression as a phenomenon or if they're contributing to the treatment refractory component of the depression. we actually submitted a grant to the NIH to look at those three groups of people. So again, the treatment refractory group, a treatment responsive depressed group, and healthy controls. And so I hope going forward we'll be able to do that. My hypothesis is that we're going to find more of these kind of metabolic disorders in the treatment refractory group, because my guess is that if you're making serotonin and we give you a medicine that makes you not destroy serotonin, we will have an effect on your depression by raising serotonin in the central nervous system. But if you have a disorder where you're not generating serotonin, no matter how much blockade we create or how much we stop it from being broken down, you may not have a response. And I don't have good data for this, but this is my hypothesis right now.
So just for me to add to what you're saying, that in particular for our lay audience, people are familiar with the SSRIs, the selective serotonin reuptake inhibitors, and the SNRIs that do the same for serotonin and norepinephrine. And part of how they work is that they slow down the reuptake, but it's based upon that it was produced in the first place. So
right.
Your point is that the effectiveness of this replacement is because it wasn't produced in the first place, and therefore you're helping it get produced, so people who did respond probably or may not have, at least to this extent, a similar kind of problem.
That's my guess, yeah.
Okay. That obviously makes a lot of sense when put into that context. What should someone do right now if they or a loved one has refractory depression? They haven't responded to full courses of treatment. What should they do, given this information that's preliminary but very important? What does a family do?
Yeah. So I think we are getting a lot of phone calls and referrals, and I think it's very important, first of all, that so many people that have depression don't get appropriate treatment. So the first thing I think is really important is that you should be evaluated by a psychiatrist who manages depression, because there are, I'm talking about this group of very severe patients who have very specific rare disorders, but there are very effective treatments for depression. And so the first thing is to make sure you're assessed and treated. If you're a patient who has had that and nothing has worked, I think that at this point it is very preliminary, but the field of biochemical genetics knows about these pathways and testing is available. And so I think as we move forward and we have more confirmatory information that this is in fact a phenomenon, that it would make sense to have a secondary metabolomic evaluation.
So the 2 points I want to emphasize them that you're making is, number one, to be diagnosed as having refractory depression requires that the person has had a number of full courses of treatment with appropriate treatment at full dosing. So There are many people who have not yet responded to treatment who may have had some treatment, but not that full course of treatment and not a couple of trials with it. And first and foremost, that's what people should do.
Yes.
So that's the most important message, and will help many people just by doing that. And then the second important point is, for those who have had that and then have still not had a response, there are some steps that could be taken even at this point in time with this preliminary information.
Yeah, I believe so.
Yeah. The one question that a couple of people have asked that makes sense is if, given your early findings of the cerebral folate deficiency in many of the people who were affected by this and the action of folinic acid to help remediate it, does it make sense in any fashion? I'm not telling you to make a treatment recommendation for an individual, but just in the broadest sense, does it make sense for people to be prescribed folinic acid even without all of the information to see if that makes the difference for them?
Yeah, this has been a real interest. This has been a question that's come up quite a bit. And I want to say that I think I have the minority viewpoint here, so I want to say that to start out. I think that there's two issues. One is folinic acid, the other is Deplin, because there was a paper recently showing some improvement with the addition of 5-methotetrahydrofolate or Deplin to an antidepressant. I think there's a couple issues with this that people should be educated about and be considering as they're moving forward with that treatment. The first one is if you have somebody who's this severe, who has not responded to available treatments, ECT has been ineffective, you're really at a loss as to how to proceed next. That's a person who probably merits a workup like this, because we've had patients referred to us who've had a trial of folinic acid and we find out they have a completely different disorder. And so you're waiting potentially for 3 years for the effects of folinic acid. And so you're committing the person to a 3-year period of a trial before you would give up on it. And once you've treated with folinic acid or with 5-methotetrahydrofolate, you can no longer test for the disorder because you're putting the metabolite in there that we would have been testing for. And so it's really a conundrum, because if you don't have access to the ability to do this cerebrospinal fluid testing and you really have no other options, I can understand why you'd want to try one of these folate metabolites. But there's a chance you're not treating cerebral folate deficiency. And then the secondary issue here is that I have seen patients who've been empirically treated with folinic acid who have horrible anxiety as a result of it. Because I do think that this folate metabolite, because it's not acted on by the body and it goes directly into the central nervous system, can in fact ramp up neurotransmitter metabolism. And so if you have an anxious suicidal person who doesn't have cerebral folate deficiency and you give them a folate metabolite, could you be doing harm? We don't really have an answer to that right now. And so I think it's something I'd proceed with extreme caution.
Okay, very good advice. And I think the key component of what you're saying is that people who are in this group of 15% non-responders really deserve and should have the full evaluation that could help them.
I do think so.
Not take a shortcut. They should have that availability.
Yeah, if it's at all possible. Yeah.
Yeah. I know that you get asked questions all the time. I've asked you some questions that's come through. What types of questions do you get asked typically about this?
I think the most important ones actually you just hit on was the question about folate and the folate pathway. I think the other issue that comes up is about how important these findings are, and I do think it's early. I think they're very exciting, but they need to be replicated. And I also get asked about who's available across the country that is beginning to work on this. Right now, as far as I know, we're the only center providing this testing around psychiatric diagnosis. But I do have colleagues at Northwestern University and at McGill who are working on getting this up and running so that we can both replicate the findings and have more accessibility for patients who have this severe form of depression. I also get asked a lot about what the implications are for this in people who've lost loved ones to suicide. And I think that this is more evidence that this is a biological phenomenon. This is a medical disorder. And so it is a life-threatening medical disorder. And we need to really look at these illnesses and at suicidal behavior as a disease process and not a behavior. And so these are the kinds of topics that come up quite frequently.
All very important topics. And I know that you have expertise in treating people who are suicidal and helping families who have tragically lost a loved one. What do you say to a family that's had that tragedy?
So this is really the cornerstone of why I started this work. I think that what's really crucial is that the suicidal brain is an ill brain. It's not. We try to apply healthy brain processing to the phenomenon of suicide, and it doesn't work like that. I'm sorry. I think that what's really relevant is that all the work that's been done looking at the neurobiology of suicide indicates that brain processes and suicidal behavior are not the same as those in depression or in healthy people. And so before I started this work, I did neuroimaging work in adolescents who had depression, and a history of suicide attempt, and healthy adolescents. And what we found is that in every task we gave these three populations, the adolescents with a history of suicide attempt had different processing than both the depressed and the healthy patients. And that remained true even when we kept the levels of depression the same amongst the patients that had no history of suicide attempt and those that did. So I think there's something about suicidal behavior as its own distinct disease process. It's associated with depression, but I think that there's a biologic phenomenon that results in suicidal behavior. And I think the message to families is everything we're looking at trying to understand suicide indicates that there are medical and biological changes in the brain. And so I think when you're asking the question of why did this happen, it's important to understand that, like heart disease or cancer or diabetes, that it's a life-threatening illness that can kill people, and it's not something that the patient chose or that the family did wrong, but that there's actually a biologic phenomenon that causes that illness. I think that's the most important thing.
I think it's a very important message for people who have lost somebody, and it's an important message for people who are at risk of suicide to help make sure that they do get treatment and the help that can decrease the risk of such a tragic result.
Right, and also to not feel shame when you're asking for treatment, because this is out of your control. This is a disease process that needs treatment.
Exactly. Just as somebody has high blood pressure, it's not their fault. One of the things that you and I have spoken about, I want to ask, which is in your study, you looked at 14-year-olds through adulthood, and given the metabolic aspects of this, potentially genetic aspects of this, I want to ask you about sort of when these things occur and take root. Are these really developmental types of disorders that may occur in childhood or at puberty? And just speak towards your thinking about that.
Yeah. So, and I think this is an important issue too. There's a couple components. There's three different things I'll bring up. One is that in our population of very severely ill patients with treatment-refractory depression, the majority of these patients had been ill since childhood, so either early childhood or at the onset of puberty. And so we're talking about decades in some cases of depression that just never remitted. And I have to say that having sat with individuals who deal with this, I admire their strength and their ability to keep going, because it's a horrible disease to live with. But I think the second thing that's really relevant is that from the field of biochemical genetics, we know that a lot of metabolic disorder that's inborn, which may be different than what we're seeing here, because this may be, a genetic issue, or it could be an environmental issue. We don't really understand. But what we know is that in biochemical genetics, many of the disorders that are inborn have their onset in puberty or at times of stress on the body. So places where these disorders will become apparent are at puberty, in a significant trauma, or in the peripartum and postpartum period, because there's so many changes in the body at that time. And what's interesting is that puberty is also the onset for a lot of our mental health disorders. And so I do wonder if the component of the biochemical phenomenon that I'm seeing here in this population, and the fact that there's onset in puberty, may indicate that this is an area we need to keep looking at in mental health because of the effects of puberty on these pathways. And so yes, the majority of these patients have had depression since early childhood or since their teen years.
Okay. I think you make some very, very important points in that. The I want you to speak a little bit about other current treatments for refractory depression,
Sure.
ECT, some of the work that's being done with rapid-acting antidepressants. I'd like you to be able to share a little bit of information with our audience about that.
Yeah. So I don't claim to be an expert in ketamine or transcranial magnetic stimulation, but I do just want to talk a little bit about my experience with it because of my involvement with this population. We've had patients come into this study who've had ketamine infusions. Many of them have had electroconvulsive therapy. Several have had transcranial magnetic stimulation, and we've had a handful that also had surgical interventions, so a vagal nerve stimulator or neurosurgery. And I want to emphasize that electroconvulsive therapy is the most effective treatment we have for depression right now. And so I think that it's important not to dismiss that because of the stigma associated with it. And in fact, I tell my patients often, if I had a severe depression, that's the treatment I would want. But the majority of the patients in this study who've had electroconvulsive therapy did not have a response. And I wonder about that because of neurotransmitter metabolism again, because what electroconvulsive therapy does is allows release from the neuron of neurotransmitters that are stored. And so again, we may have a situation where they're not present. Ketamine infusion, in the small experience I've had, has a very good effect for a very short period of time. And the concern I have in my population is that I see people, we had one patient who got a ketamine infusion and then flew to see us, which we didn't know was going to happen, so that he would be well enough to come to the study. But what I see is that after the period of ketamine's positive effect, there's a significant mood drop. And I've attended lectures about ketamine where there's been a conversation about the fact that maybe it's because the patient feels well for a period of time, and then when the depression comes back on, that mood drop is so severe. But I also think we can't rule out the effect that ketamine may have in worsening mood after its effects wear off. And so I have some concerns about having a population that's at risk of suicide and then having a short-acting medication like that, and how helpful that really is. I would defer to my colleagues who know more about ketamine. I've seen good effects from transcranial magnetic stimulation in moderate depression and mild depression, but I have not yet found a patient in this population who's had a response. And again, this is a very small N, but I haven't seen a good response to TMS in this population.
Good, very good overview, and I think especially in terms of ketamine and the work on rapid-acting antidepressants, that has tremendous potential. We're still not fully ready for prime time yet. We need to learn the exact dosing. We need to learn the side effects, what to do for continued effect when it does work, and maybe some of the byproducts of ketamine that are being studied might be the real answer for this rather than ketamine. So I think it's still something that needs a lot more work. And your point is very well taken in terms of the risks of getting better and then not continuing to be better. For the patients that you've had in your study who have shown improvement, has that improvement continued? Has that been a steady state, or has there been up and down?
So in the study, I think I'm talking about probably 6 individuals who've come to me who've had ketamine infusions. Mm-hmm. And of those, I've had 2 that had a short period of improvement, and then it dropped off, and the others reported no effect.
No effect. Okay.
But again, I'm talking
broader, right? In your findings, where people respond to the treatment that you've initiated, does that positive response, have you found that that's continued moving forward?
So far, yes, but so far everyone we've treated who's responded has had a stable improvement, but I hesitate to say that will be the case. That's just what we've seen so far.
And they're also on antidepressant medication along with the treatment that you're giving?
Yeah, some of them are. So the first young man I talked about, he, when we first started the ciprofloxacin replacement, we also gave him serotonin precursor. He now only takes the ciprofloxacin replacement, And this is a phenomenon I've seen in this very small group of people, that it appears that once the cypropirin starts taking effect, they'll get some serotonin side effects and we'll start backing the serotonin down. Again, I don't know, but I think that what's happening is they're generating serotonin. And we do take blood levels of serotonin, and we see that their levels have normalized. He continues to do well with cypropirin alone. He does at times take a stimulant, which helps with his concentration. And so he had a long period of being on no psychiatric medications at all, but now he is on a stimulant as well. The patients with cerebral folate deficiency, I have tended to still have them on SSRIs when they're coming back in for follow-up. And again, we're not treating, we send them out for treatment and then come back for follow-up, so it's variable. And so I don't know how much I can comment on this, but what is true is that prior to their supplementation, those antidepressants weren't working.
Right.
Yeah.
And in turn, you spoke about the potential side effect of increased anxiety and what the risks associated that with folate replacement. Are there other side effects with that, and also are there other side effects with the other replacement approaches that you've taken?
Sure. So with the folate, there's a slight risk of flushing. I've only had one person have that, and then the increased anxiety I've seen in about 3 individuals. It is, because it really is folate, it's a similar risk to taking a multivitamin. The difference in the risk is that you now have a form of folate that the body is not managing, so it's already broken down. So you're increasing the accessibility of the folate in the central nervous system, I believe. The cypropirin, I've had very few side effects with cypropirin, and again, it's a small molecule that's present in the body. But I want to say one thing about that: it's not a completely benign treatment. Even if you need the replacement, because we don't know long-term what the effects of always having that molecule on mean. You know, by me replacing that and giving a prescription, the body's no longer controlling levels. It's controlled externally, and I don't know what the long-term effects of that are, of constantly having that small molecule available. So I think it's important to say. And it's certainly not something I would give without knowing there's a need for replacement, because that could in fact cause a pretty significant problem with neurotransmitter genesis without knowing that you have a disorder. So you wouldn't want to give, for example, empiric tetrahydrobiopterin to see if somebody improves.
So, which speaks towards what you said, even with the folate replacement, that you really want to have that diagnosis before giving the treatment.
Right. And when giving the serotonin precursor, I think that is probably the most dangerous thing. So, which I should emphasize, you can buy 5-HTP at general nutrition centers or at Rite Aid, or a pharmacy, but you should not be taking that without the protection from carbidopa, and you shouldn't be taking that if you have normal serotonin levels, because you can cause hyperserotonemia, and hyperserotonemia will cause hypertension, elevated blood pressure, elevated pulse, dehydration. It can be a dangerous thing. So I think of these, the one we know that there's a significant risk at the time of dosing is the serotonin replacement.
All very important and good points. Lisa, I want to again say thank you for the work that you've done, the work that you continue to do, and to me, what you're doing offers tremendous hope for so many people, and I really appreciate your time taking the time to speak with us today, and the ongoing work that you're doing. So thank you very, very much.
Thank you for having me, and thank you for the support of this work.
Well, you're welcome, and thank you. I also want to thank everybody for joining us today. All of the research we fund is made possible through private donations. And if you'd like to make a contribution, please visit our website, bbrfoundation.org, or call us at 1-800-829-8289. This webinar has been recorded. If you missed any portion of the presentation or would like to share it with a family member or friend, please visit the webinar page on our website. Also, I ask you to please check our website for future webinar programming. Thank you again for joining us, and enjoy the rest of the day. Take care.